Hi everyone, I hope you all are doing well. I am going to be talking about Chapter 15, which covers the quality improvement organizations and continuous quality improvement in Medicare. To highlight just a couple of things, quality improvement organizations include places like nursing homes, home agencies, physicians' offices, and many other places. Medicare within quality improvement organizations now include new innovations besides licensure and accreditation. They also are independent contractors with Center for Medicare or Medicaid Services, which stands for CMS for short. QIOs or quality improvement organizations must also possess specific staff skills, including medicine, nursing, health education, and others. When considering assess, analyze, and adapt, first thing that comes to mind is with peer review organizations or PROs, which they establish many quality metrics and they work with clinicians and hospitals to identify quality improvement projects. Analyzing QIOs are data-driven national networks with support. Continuous quality improvement strategies within Medicare include strategies that what those strategies are based off of are expected to improve healthcare processes and outcomes through their partners. Some variability and flexibility that exists for contract arrangements. They can approach individual patients directly, unique in working across the continuum of care, and evaluation is through the performance of contracts. Adapting with QIOs, they've shown solid improvement in the health at the physician office level, but less so at hospital levels. And one way we can kind of adapt to this is to alter that system to fit a bigger scale, such as a hospital. Program assessments were conducted in the early 2000s with inconclusive findings overall. So these inconclusive findings are not going to help us move forward with positive changes, and so we need to ask ourselves questions like, why were these results inconclusive? What can we do to obtain decent results? And once we find those results, what changes can we make within the Medicare? So I also took some information from the QIO's website, and it says, quote, "We support a person-oriented model of care and help reduce provider burden so they can spend more time focusing on patients. To do this, the QIO program has two types of QIOs, Quality Improvement Innovation Networks and Beneficiary Family-Centered QIOs," end quote. So, also on this website, they state 6 priorities of the CMS Meaningful Measures Framework, and that includes making care safer for reducing harm caused in the delivery of care, strengthening person and family engagement as partners in their care, promote effective communication and coordination of care, promote effective prevention and treatment of chronic disease, work with communities to promote best practices of healthy living, and make care affordable, which is one of the most important things when considering quality and affordability. Those two tend to conflict. Last thing I'll talk about is identifying the challenges that limit the quality and outcome assessment in Medicare. So earlier I mentioned that specific skills are necessary. Hiring staff that possess those certain skills and being able to maintain their skills while they're still within the system is very important and is time consuming and can also be expensive for just maintaining that training. Another is adapting systems to the level of care. So earlier we talked about how it was a struggle, like how QIOs were good at the physician office level, but needed improvement in order to go to the hospital level. So being able to adapt to those different size of scales would be very important in considering the efficiency of the facility. Achieving quality of care while still making it affordable. Like I said, quality of care and affordability tend to counteract each other, And so being able to find that balance between the two to better our patients would be best, especially within the Medicare field. We want to take care of our older population because they tend to be more vulnerable, along with their family members. They're also affected by this too. So, and that is the end of chapter 15.